Good morning, everybody. I would like to thank John for the kind invitation, to thank also Eva and Bertrand Coiffier to have organized such meeting. And I will speak about marginal zone lymphoma. If I can have my slides, please. Okay. So as you know, marginal zone lymphoma is in fact a group of disease, and depending on the site of involvement, you may have mild lymphoma, which involve extranodal lymphomas, which is the more frequent disease inside the marginal zone lymphomas. Then the other two diseases that are defined by the WHO classifications are the splenic marginal zone lymphoma that will involve the spleen, and the nodal marginal zone lymphoma that will involve the nodes predominantly. Then, in terms of clinical aspect and presentation, you will have also patients that will arrive at your hospital with disseminated disease, with either mild lymphoma plus peripheral nodes or disseminated nodes and spleen involvement. You will have also, you may have also patients with only leukemic phases of marginal lymphoma with only lymphocytosis. This disease is very interesting in terms of physiopathology because there is a unique concept with this chronic antigenic stimulation that will bring the disease to a mild lymphoma or a splenic or a nodal marginal zone lymphoma. And this antigenic stimulation may be due to autoantigen in mild lymphoma from the thyroid, salivary gland, or lung, or because of infection, and of course, the most known, the most studied, and the most published is about Helicobacter pylori and gastric mild lymphoma. It has been also recognized that Campylobacter jejuni in intestine, Chlamydia psittaci in ocular adnexa, and Borrelia burgdorferi in skin may also produce and induce the transformation of B cells through mild lymphomas. There is also a very important either virus, the hepatitis C virus, that have been linked and associated mainly to splenic marginal zone lymphoma, but may be present also in nodal marginal zone lymphoma and mild lymphoma. So this mild concept is a unique concept in mild lymphoma, and we think that this chronic inflammation creates a special microenvironment that may be in the future very interesting to target. In terms of diagnosis, this marginal zone lymphoma has no specific markers to make the diagnosis, and is characterized by the immunophenotype. The cells are usually with Mutated scores below 3. All are CD20, of course, positive, BCL2 positive also, and they are associated with some cytogenetics elements, very characteristic, such as for most of the patients, half of them, the deletion of the 7q, and trisomy 3 may be present in 1/3 of the patients. You have also specific translocation in mild lymphoma, such as T1118, T14, T114, and T314, but there is no translocation in the splenic or in the nodal marginal zone lymphoma. In fact, this genetic alteration in mild lymphoma affect for all these translocation several genes that will bring the NF-kappa B signaling activated. So the most common of this translocation is the T1114, and is very common in the gastric area. And you have also the activation, the deregulation of BCL10, so MALT1, FOXP1, that all, as I said, will activate the NF-kappa B pathways. You have also the activation of these pathways by deletion or mutation of A20, which is very frequent in multiple lymphoma and have been observed in more than 40% of the patients. The T11-314 that will overexpress the FOXP1 has been associated with a poor outcome and a higher risk of histologic transformation for this multiple lymphoma. But it's very rare. It has been described in less than 10% of the patients. So all this alteration in multiple lymphoma will alterate and will activate the NF-kappa B pathways through these major pathways, the canonical or the non-canonical pathways, the TLR or the BRAF and CD40, and also via the mutation of genes implicated in the BCR signaling. And when you look at the non-multiple lymphoma, so the marginal zone lymphoma from the spleen or the non-marginal zone lymphoma, you can see that you have the same pathways that are activated because of mutation of genes, so the NF-kappa B pathways, the TLR pathways, the BCR pathways, and you have also the Notch pathways, which is very deregulated, either in the splenic marginal zone lymphoma and the nodal marginal zone lymphoma with Notch2 and Notch1, but mainly Notch2 mutation occurring in 20-25% of the patients regarding the different publications that have reported this alteration. So in terms of marginal zone lymphoma, compared to the other lymphomas, the B lymphomas, you have a unique pattern in this splenic marginal zone lymphoma with this deregulation of Notch pathways, TLR pathways with mid-88 and NF-kappa B pathways with the canonical and non-canonical pathways. And so among particularly the other small B-cell lymphoma regarding Waldenström disease, hairy cell leukemia, mantle cell lymphoma, CLL, splenic and nodal are characterized by a specific mutation profile genes. I will focus on three of them. So mid-88, just to point out some ideas that mid-88 is usually presented specific to LPL, lymphoplasmocytic lymphoma, Waldenström disease. But however, I would like to point out that in 15% of the patients with splenic marginal zone lymphoma, it will be present. In that series, you have 13 patients and with a mutation of mid-88. And in these patients, 3 of them have a very high level of IgM paraproteinemia. So this mid-88 is for sure a valuable tool for diagnosis of LBL, but may be present in splenic marginal zone lymphoma. So it's not a clear-cut diagnostic tool. We have to be cautious about that. The second one I would like to focus on is has been reported very recently, mutated in 20% of the splenic marginal zone lymphoma, the KLF2, Krüppel-like factor 2, which is a negative regulator of the B cell clonal expansion. And it will activate some pathways such as cell cycle apoptosis and cell trafficking. And another pathway that will be also very interesting, because in terms of therapeutic targets, it should be interesting, the JAK-STAT signaling genes, and particularly the PTPRD genes, which are mutated in nodal, particularly in nodal marginal zone lymphoma. And this has been reported by David Rossi at last ASH meeting. All these pathways, the NF-kappa B, BCR, AKT, and CD40 pathways have also been enlightened by other kind of technical tools, such as gene expression profile analysis and miRNA profiling, and all the enforced the message that these pathways are very important in marginal zone lymphoma, especially in the splenic marginal zone lymphoma. So in conclusion, for this first part of the talk, mutation of genes regarding the marginal zone lymphoma development are characterizing 60% of the marginal zone lymphoma. So TLR, BCR, BRAF, and Notch pathways are very important in terms of this marginal zone lymphoma, and we have also other pathways that may be important, such as JAK-STAT in the nodal marginal zone lymphoma. So there is common alteration in the 3 subtypes of marginal zone lymphoma, but using different mechanisms, either mutation or deletion in the splenic and the nodal marginal zone lymphoma. And in the mold lymphoma is more because of this translocation that we will have the activation of these signaling pathways. And what is also interesting, and it has been reported last year, is that when you have only the early stage of lymphocytosis linked to the marginal zone lymphoma, so only the leukemic phase, you have in this kind of disease that I think is the early stage of the splenic marginal zone lymphoma, the same pathways and the same genes that are mutated. So you have the activation of the Notch, the NF-kappa-B, the TLR, the BCR pathways, and the MAP also a little bit, but the same pathways are already activated in the early stage of this marginal zone lymphoma. In terms of therapy, this marginal zone lymphoma, there is currently no standard treatment to take care of these patients. You can have a watch and wait decision, for example, in the early disease and the early phase of the splenic marginal zone lymphoma or early stage of mold lymphomas. You may propose to the patient local therapy with radiotherapy or splenectomy for the splenic marginal zone lymphoma, or rituximab alone, rituximab chemotherapy such as R-chlorambucil in mold lymphoma or bendamustine. There is only one randomized trial in marginal zone lymphoma that have been reported by Imerizuka in 2010, and there was 3 randomization between R versus R-chlorambucil and chlorambucil alone, and we will have this year as a proposed studies for Lugano the actualization of this trial, and several other combinations have been proved to be efficient in that kind of lymphoma, such as cladribine, chlorambucil plus metoxantrone, fludarabine also. I think that R-CHOP are to be used only for the cases with transformation, histologic transformation or bulky mass. So in terms of response to this treatment, it was difficult to make very condensed results. So I chose to focus for the mold lymphoma on the publication that have been reported by Emanuele. So R-chlorambucil Ford will induce a complete response around 80%. For the splenic marginal zone lymphoma, you may choose either R alone or splenectomy. There is a lot of controversy in the literature on that treatment, and R alone has been reported by the Greek to induce a complete response in 71% of the patients. And for nodal, the series are very heterogeneous, and there is few patients only, and R-chemo, whatever the chemotherapy, Benda, CVP, or CHOP may be proposed to the patients, and you will have around between 30 to 80% of complete response, depending on the series and the treatment. And these are the survival, the progression-free survival, and the overall survival. And this disease is a very indolent disease. And what I would like to underline is that in this series that we reported with 100 patients treated by splenectomy alone, half of the patients that died during the analysis, in fact, died for another cause than lymphoma. So just to point out that this indolent disease, the patients are living sometimes their life and they are dying not because of the lymphoma. So what is next? So to improve on standard therapy, that will mean that maybe we will have to improve the progression-free survival. And for example, in the nodal, we have really to make an improvement. Is it time to think about cure of the disease? I don't know yet. Or the goal will be maybe to have the same result with no toxicity. Actually, regarding the drugs that have been tested in this lymphoma, we have alternative anti-CD20 with obinutuzumab, G101, or antidrug conjugate, or newer agents. Maybe this newer agent will be more efficient than this alternative anti-CD20 with bortezomib, lenalidomide, or drugs targeting PI3 kinase mTOR, targeting BCR, maybe also interesting in that disease, as we have seen, and targeting also BCL2, maybe also an option. Just going through the different studies, in fact, when you look at these studies, you have very few patients that have been included in these studies with marginal zone lymphomas. So, for example, in the Gauguin study reported by Gilles Salles in 2013, you have only 3 patients, so it's not possible to say anything. In the GOS study reported by Lorisen, 26 patients was presented with non-follicular lymphoma, but we don't know what it was exactly. The antibody drug conjugate with anti-CD22, anti-79B. Again, very few patients was included in this study, so it's not possible to say anything in terms of result. Bortezomib, it has been reported by 2 teams with 16 patients or 32 patients by Anarieta Conconi, and we have an overall response rate between 50 and 80% of the patients, but the neurotoxicity was largely very high, so I think is not to be used in marginal zone lymphoma or mild lymphoma as it has been proposed. It has been also reported by Marcus Raderer, a very interesting study with lenalidomide in pretreated or non-pretreated or in frontline patients with 6 or 8 cycles of this association, and you may see that there is a lot of response, overall response rate 86% and complete response rate 65%. But again, there is a lot of toxicities regarding hematological toxicities, leukopenia and anemia. Everolimus had 101, which is a mTOR inhibitor that has been proposed to 30 patients with relapse and refractory marginal zone lymphoma with very few complete response. Only 1 person had a complete response. And in terms of toxicity, you can see that there is a lot of toxicities and mainly hematological toxicities, so it's not acceptable for indolent lymphomas. This was the conclusion of the authors. The PI3 kinase inhibitors, idelalisib, 15 marginal zone lymphoma have been treated with an overall response rate at 47%, a little bit less than the other indolent lymphoma, follicular, small lymphocytic, and Waldenström disease. Copanlisib, there was also reported by Martin Dreiling at the ASH meeting. 3 patients with marginal zone lymphoma among the 33 included, and 2 of the 3 patients responded. Ibrutinib, that have been reported in GCO 2013 with only 4 patients with marginal zone lymphoma with an overall response rate in 1 patient to the 4th. And on TBCL2, 3 patients have been included in this study reported at ASH meeting, but we don't know exactly in the abstract, and I was not at the presentation, and we don't know in the abstract what was the response for the marginal zone lymphoma. So in conclusion, for the targeted therapies in marginal zone lymphoma, we have still a lot to do because there is few patients included in the studies dedicated usually in indolent lymphomas, and we have to work on that specifically in marginal zone lymphoma. But I think it will be very important to have stratified approaches on these different entities. I said that these entities have the same activated signaling pathways, but I'm sure that we have to dedicate studies with stratified approaches based on these entities, mold, splenic, and nodal lymphomas. We have no IPI for marginal zone lymphoma except for the splenic that have been published by Montalban in the 2013 based on 3 factors: hemoglobin, platelets, LDH level, and extrahilar lymphadenopathy that showed here great differences between 3 types of populations. And we also submitted to Lugano an IPI for the mold lymphoma based on the ILG19 studies. Maybe we will have also some biological factors that will have a pronostic power, such as NOTCH2 mutations, that when is mutated are clearly associated with a poor prognosis in terms of progression-free survival and overall survival. We have also to work on the evaluation of responses with PET scan and MRD. We are currently in the BRISMA trial evaluating the MRD as predictors in blood and in bone marrow. So in conclusion, there is not a lot to say in terms of targeted therapies because we have still to work on that disease very precisely as a unique models to target some very important signaling pathways such as TLR, BCR, NOTCH, NF-kappa-B, and JAK-STAT. So we have to put patients in clinical trial to make more advances for these patients. Thank you very much.